All right, everyone, we're going to go ahead and get started. Thanks for everybody for joining. Today we have a didactic presentation from Kelly Lemon. We don't have an official case per se, but if there's anything we need to discuss related to the didactic or something else, please just feel free to put it in the chat or unmute when we get to that part of the session. And for those who have just hopped on, please remember to put your information into the chat, your name, your email, your organization, and your credentials. With that being said, I will turn it over to Kelly. Go ahead and take it away.
Sounds great. So let me just do one quick thing, just because I threw my PowerPoint over there on the other screen, and then I didn't want to be like looking over at the other side. So hello, everybody. Thanks for coming to hang out today. Everyone should be able to see, hopefully, just a nice big PowerPoint in a hot second. So I'm Kelly Lemon. I'm a certified nurse midwife and women's health nurse practitioner. I live here in Morgantown, West Virginia. A big component of my job is doing partially prenatal care with the general population, and then a huge focus on individuals with substance use disorder. Something that tends to come up a lot is how we manage pain for people that have substance use disorder, and in particular, people who are on medication-assisted treatment. And so I'm hoping that when we all walk away from here today, that maybe we're a little bit more comfortable with that. I don't have any significant disclosures to tell y'all about. There's just a couple abbreviations if you need to like flip back after the fact and look through those to figure out what some things are. I'm trying to target this so that however you are interfacing with the population, if you're a peer, if you're a social worker, if you're a nurse, if you're a provider, if you're someone that's working through like community engagement or a counselor, the goal is not that you're like leaving and having to like give prescribing advice to people, but more so that you're able to talk with the people that you're caring for, help them to feel empowered, help them to like know what their options are, and to be able to help them learn how to like really advocate for themselves, maybe when they're not being given the best information. Some specific concerns that we come across whenever people have any kind of medications for opioid use disorder, or if they have a substance use disorder during pregnancy, is that a lot of our data is actually pretty limited. One of the biggest populations that we tend to just immediately remove from studies are pregnant people. This is a complex population that's going through a lot of physical, emotional, and psychological changes. This is a population that has a really predominant rate of coexisting mental health diagnoses and might have some additional history of physical abuse, sexual abuse, or trauma. And a lot of that can resurface during this time. And it's something that we have to think about. The other piece in this is that a lot of times the normal treatment path that we would like not even blink an eye at in the rest of the population, we shy away from because we have a fear of harming the fetus, and that causes a lot of limitations to how we're taking care of our pregnant people. And so that's something to keep tucked away in the back of your brain. When we think about pain management, this is not something that's usually heavily discussed in substance use treatment. And I'll tell you that I'm guilty. I know that when I'm starting people in clinic on Suboxone, like it's not like my main thing that I jump in is like, hey, let's talk about acute pain management for you and what that looks like. That's usually something that gets tackled as it comes up. And I know this to be true, and I'm also guilty of it. When the acute pain is coming up or when the stressor is coming up, that's probably not the best time to try to get into like the nitty gritty of informed consent for that. So we really need to be doing this on the early side and making sure people know. Patients have a really significant fear that their pain's not going to be managed. Some will view using pain medication as a relapse or a return to use, just depending on their own personal beliefs and their own experience. They have a fear of being judged, stigmatized, or disregarded. When we think about pain management on the provider side of things, in that core belief of do no harm, a lot of times providers will be so afraid of pushing that person into a return to use or opening up the pathway for that, that it'll actually cause more harm than good. A lot of times it's coming from a good place, but they're not trying to put that person in a situation that would put them at risk, but that actually causes a lot more disruption in pain management. Some providers do have the assumption that the person is drug seeking. Some people just have an inadequate knowledge of how medications for opioid use disorder work, because this is not something that's just completely embedded in your medical training and your midwifery training or in your nursing training. The other tough thing too is that while protocols exist, or like maybe an institution like goes and does all the work to make sure that they have a really straightforward plan, they are not also actually followed all the time. So there was a really interesting study that was published in 2022, going back and looking at like a quality improvement project they did for post-op pain control. And only 41% of the people after the initial QI period ended, like continued getting the protocol. So even when it's like right there in front of us, sometimes there can still be that lapse in what we're doing. And so that's something to keep in mind too. When we are talking about risks with substance use disorder treatment, risks with pain management, the thing that you will always hear me say when you're balancing risks in pregnancy too is that if your pregnant person or your birthing person is not healthy and safe and okay, your fetus is not healthy and safe and okay. And so we obviously don't want to cause frank harm to our baby that's forming, but we also have to make sure that the person that's helping grow that baby is fine. And when we have a mom who's experiencing pain, that is also not good for our baby. So she has an increase in heart rate and cortisol, and that can lead over into some fetal effects. So if you need something to reframe your brain around, that can be like a helpful start to like, okay, and if I don't manage her pain, that's also causing harm. So let's try to figure out how to do the lesser evil there. When we look in general at how to go about pain control, we do know that higher doses of pain medications and opiates might be needed for peripartum pain to be effective for those who are on a medication for opioid use disorder, and we'll get to that in a little bit. We do know that if we have an increased risk or an increased exposure to opiates, that could increase their risk for use. We also know that if we're not controlling people's pain, that's probably going to push them to go back to using more so, because they're going to try to do symptom management. And so making sure that we're just doing appropriate and close follow-up with people and support and leaning into other types of pain management as well, besides just opiates. And so I'm always a big patho girl, and I like examples. And so when I'm trying to break things down for people to understand like what's going on with their bodies, I think it's always helpful to like really go step by step through of like what are the changes that are causing the things that are happening to us. And then I always live for examples. So we're going to start with this little case study that's kind of like embedded in, go through some things, then I'm going to swing back around to try to tie this together for us. So we have a 24-year-old patient. She comes in the clinic for an OB visit. She's 26 weeks pregnant. She has a history of opioid use disorder, and she's taking Suboxone 8 milligrams daily, and she follows with someone in Pennsylvania, out of the state, out of my medical system. She says that she's only taking 8 milligrams daily. When her provider found out she was pregnant, they started immediately giving her 16 milligrams because they didn't want her to have withdrawal symptoms at all. And she shares like, I'm getting 16, but I'm only taking 8. I never changed my dose. I was uncomfortable with that. However, in the last 2 weeks, she started feeling sweating. She was having leg cramps, insomnia. She was yawning a lot more, felt like she couldn't get a deep breath, irritable, and having back and hip aches. So she's coming to me just for prenatal care and asking, what do I do? Do I just like start taking the full 16 milligrams? I'm afraid that this is withdrawal symptoms. My provider told me that withdrawal in pregnancy was really bad. Help me. What do I do? So be brave, unmute, tell me, what about this concerns you? And like hearing this.
So I would say that at 26 weeks, she's not quite into her third trimester where we expect a large volume, distribution volume to quote unquote dilute out any medications.
Mhm.
So the provider instantly putting her on 16 milligrams a day because she might go through withdrawal. It's like planting seeds in her head that she's going to have withdrawals. Certainly, there is something to be said for increasing dose as you get further along into your third trimester. However, not there yet, and this might be more of her own dealing with the pregnancy, dealing with her substance use disorder, um, feeling guilty that she has cravings to use, and she's afraid to hurt the baby. And will she do better if she takes medication as opposed to going back to a relapse? So there's a lot of stuff going on here.
Oh yeah, no, perfect. You nailed it. Anyone else have any thoughts or any concerns? Or what do you think is going on? Anyone have any different
I
thoughts?
also, have some concerns that she doesn't feel comfortable talking to her prescriber directly. And I'm glad she has you, but it because perhaps of the way the increase occurred or whatever, she doesn't really feel comfortable having this conversation directly with her prescriber.
Yeah, agreed. Because this is someone that I happened across in clinic, had no idea at all that I worked with people with substance use disorder. Just knew me as a midwife that she was seeing. Any other thoughts?
I'll say in that case, I'll have something that's more of a comment. It's really awesome that she is getting prenatal care. So we see a lot of times that our moms that are in treatment, sometimes they wait to get prenatal care because they're worried about CPS.
Yeah, for sure. Good. All right. So in going through this, I'm going to walk you guys through some of the different things that'll come up frequently at this phase of the pregnancy. So file this one away. We're going to come back to this here shortly. So told you I'm a patho girl. So physiologic changes of pregnancy. I could talk about this for like 3 hours straight, and I'm gonna like let you guys skim and read. Please just know lots of things are changing. We're kind of hardwired that when something goes from different, when we have like a new symptom, it means something is bad or wrong. And a lot of times, like a symptom or a change in our body is kind of our body's way of going like, yeah, something's different. Just be aware of this. And it's not always bad. So, for example, with all of these physiologic changes of pregnancy, I would argue that when you start getting nausea and vomiting and heartburn and breast tenderness, it tips you off if you're like, I'm having all these weird symptoms. I wonder what's going on. Ooh, what if I'm pregnant? And then you find out you're pregnant and you start making a change. When people are having like signs of withdrawal, their body is letting them know, hey, something is going on with me and I'm not right. And it helps them to figure out what we need to do next to feel better. When we have a headache, maybe that's our body saying, hey, you need to drink water today, silly pants. So symptoms can be very frightening if we don't know what they're for, and if we immediately associate them with something terrible. Whereas a lot of the things that you read on here, you're just like, oh, poor appetite, hemorrhoids, vomiting, my joints hurt, I'm dizzy, I'm lightheaded, I have some swelling, and I feel a lot more stressed and kind of short of breath. Could sound like really terrifying symptoms. If you WebMD that, it's probably going to tell you that you have something terrible happening to you, or it could just be pregnancy things. And so always trying to tease out in these changes that are happening, all of these discomforts that come up. But discomforts is quite frankly putting it lightly. All of these things that are normal to pregnancy, very much not normal for what our body's typically experiencing, right? So you'll notice a lot of these are also things that our lady from our case study was experiencing as well. Then we just switch over and we start thinking about when people are on a medication for opioid use disorder, or when people are taking like chronic opiates, they can have constipation, they can have skin changes, they can also get dizziness and fatigue. And so we start to see a crossover in that. Then we consider common signs of withdrawal that we tell people to be on the lookout for, because they need to tell us so we know if we need to adjust their meds. Nausea, vomiting, like sweating, mood changes, body aches, having leg cramps. And so when you combine all of those together, all of these are present in people that are pregnant and people that are going through withdrawal. And you start to see where it can get really confusing to tease out. So it's a matter of trying to figure out, how are you taking your medication? Are we taking it appropriately? Are we taking it little pieces throughout the day just whenever we need it? Or are we like firm on a regimen? That's usually my starting place when I'm trying to tease out, is this pregnancy discomforts or withdrawal? So making sure people are taking their medication on a regular schedule is a huge piece. They can do a split and do in the morning and in the evening if they need to. That is like fine if they need to make those little changes. But I usually tell people, like, once you pick your regimen, stick on it, because what I need to see is consistency. And if there's like phases, are we getting sick right before our dose? That's going to tell me maybe we need to change something. Or is it happening all the time? And that can also help me to tease out. Then going through the symptoms, and for a lot of those in pregnancy, there are things that you can do to improve it. So if we provide education on some of those discomforts we see, and then we also go through some of the remedies that we can do, and those don't work, then I'm going to start thinking more withdrawal symptoms, versus if we have low back pain and I can give you interventions for that and it helps, then maybe it wasn't withdrawal. Maybe we just really needed to optimize our management for low back pain in pregnancy. So we're going to go through really quickly some of these. Again, I could go on for a long time. So if you ever want pregnancy discomfort 101 management, email me and let me know. But low back pain, people frequently get a lot of like deep gnawing pain. Most of the time when patients will be like, I'm having this like pain and restlessness and I can't get comfortable in this ache, it's usually at bedtime, whenever they're laying down. And this lovely graphic of this very pregnant person, you can see how the spine starts to like push in completely and get this big old curvature in it. Just imagine how that's going to strain on all of the vertebrae and the muscles and the anatomy. And so there's a variety of interventions we can do for that. Hot and cold therapy, Tylenol, support belts, yoga and stretching. People want to just, I think they just want to smack me whenever I'm like, you should do some yoga and light activity and stretching, but it helps so much. Even if it's that gnawing pain as soon as you get in bed, if you get up, do some like stretching, get better oxygen and blood flow to that area, it'll usually improve it. Manual therapy is really underutilized, but can work exceptionally well. And when we think through what those supports can look like, there's a variety of different like gizmos and gadgets and attachments and suspender belts and all kinds of stuff that can help to like lift and support the belly, the low back and the pelvis, so that people can get some comfort. A lot of times insurance will pay for these. I've managed to get Medicaid to pay for these sometimes. Or you can just order them cheap, depending on how much people, like what people have access to. I know this is something that we try to stock in our baby pantry for the ACE program for when people are having really bad low back pain. Exercise and movement, really, really helpful. That can be free. And there's a lot of really great videos online that I usually will like direct people to as well. Leg cramps is probably the biggest one I see prenatally, where people start really wondering if they're having withdrawal symptoms. When we think about that huge curve we started getting in the spine, every day throughout pregnancy, the way gravity pushes down on the body and the spine and the anatomy, it changes like our center of gravity and how we're moving and walking and using our body daily, which is pretty cool. The less cool side of that is everything pushing down and changing that anatomy gives you a little less venous return, decreased low O2 to the lower legs. I can't talk today. It's good. People get dehydrated. Maybe we're a little bit nutrient deficient. All of those things together will cause people to get like restless legs and leg cramps. Variety of things that you can do for those that are really easy, pretty low cost and pretty effective overall. Swelling, really common, especially with people that have had any kind of prior IV drug use, just because that peripheral neurovascular system has taken a little bit of damage. So one, educating people that is really common, also giving them warning signs for preeclampsia, but trying to maintain that balance so that they're not freaking out the whole time that they're going to have preeclampsia. Monitor, but decreasing some of that anxiety can help a little bit. Something as simple as compression socks and braces can help with that. This swelling is also going to happen in the hands, which can be really daunting and uncomfortable for people. And if you're constantly like getting your hands to lock up, some people will get tremors in their hands and start like going through that. Am I having withdrawal symptoms because I'm getting tremors and numbness? And so doing light exercises, doing simple stretches on our hands can also help with that. Braces and ACE wraps, super great for supporting those hands, especially if you're getting carpal tunnel of pregnancy, which can happen. Headaches is one of the biggest ones that I see that people struggle with. And they can be caused from a variety of different things. Honestly, like teasing out that cause is going to be the biggest one. Your easiest and simple fixes are going to be drinking water. No one's drinking enough water. And making sure that we're using Tylenol appropriately dosed as needed. Because something else that will frequently come up is that people will sometimes get in the mindset of like, I've been told that if I have pain, I will need higher doses of pain medication. And so maybe it only says that I need 1 Tylenol, but I probably maybe need like 3. Tylenol is going to work just as well with someone on Suboxone. It does not go into that same receptor that is getting covered by the Suboxone, the Subutex, the methadone, or any of those. So still normal doses of Tylenol, and making sure people know what is unsafe. So above 4,000 grams a day is too much. And so we're going to flip it back to our lady. I know we just like went through really quickly on some of your prenatal things. So as a recap, she's 26 weeks. And as Dr. Wonderjean has already pointed out, we're not expecting her Suboxone to be clearing through her system overly quickly at this point. She's having sweating, leg cramps, can't sleep, yawning. She's irritable in her back and hips ache. What would you guys recommend? What would you tell her to do? I'll ask someone to be brave again.
Everything that you just said in the last 10 minutes.
You're just gonna like hit her with the entire thing. You're like, here you go.
Why not? Why not? Back brace and Tylenol and yoga
You're gonna
and
be like,
just
here's the
and
recording.
the reassurance, I think more importantly, that her symptoms don't necessarily mean that she's having withdrawals. I think that's what people really want to hear more than anything else. Am I losing my mind? Am I having relapse thoughts? Or no, you're pregnant, period. And this is what commonly happens. And a lot of times, just that reassurance from the provider kind of gives them that level of, okay, if it gets worse, I know who I can come back to and ask again and work through the process and take her recommendations and see if that really helps. And a lot of times when they do those things that we recommend, and those symptoms go away, they're like, whew, okay, I don't have to worry about it. I'm good.
Yeah, perfectly said. Absolutely. Mhm. And so, as a recap, beautiful. And then my thought would be if I gave her all of these things, and this is a lot. So I will say that when I see people prenatally, like it's a lot of follow up afterwards. It takes like, but the extra like 5 to 10 minutes that you do is really worthwhile. Is like if I'm gonna sit down and be like, okay, like let's talk about the sweating. Let's talk about your backache for your backache. Let's get a belt. Let's do this. Let's do this. That's overwhelming. She's not going to remember half of that because pregnancy brain fog is a total thing. So I will usually like go back to my little desk and like type it all out and send it to that person via my chart so that they have like like we talked about today. Like your back pain could be from this. Like you can try blank, blank, and blank. Please let me know if these things don't work. So that you can like circle back. And then it also opens up that communication so that they're not just like, all right, I went, I asked, and like now the book is closed and I can't reopen that conversation. I never want people to feel like just because we're like, that's a common discomfort, that we're blowing them off. Because while it is common, it is not common for them. It is common for me, who saw 22 people that day. It's not common for them. So something to keep in mind to make sure that they can have that reference that they can go back to, because otherwise that's really overwhelming. Really quickly, just as we're going to do a quick recap on your medications that you might come across for opioid use disorder. So most commonly, you're going to have your methadone, your buprenorphine, or we're starting to see a little bit more with naltrexone, which is a bit trickier and has a whole other management aspect that we're not going to talk a ton about. Mainly, I'm just going to focus on methadone and buprenorphine containing products. The thing to really keep in mind with methadone and buprenorphine is that while there is some analgesic effect that people can have with it, they are getting this regularly and they are getting this daily. And so their daily dose, they're going to be tolerant to. And so that is not an appropriate replacement for pain management. You're going to hear me say that several times. Methadone requires daily dosing in an appropriate clinic setting. In the hospital, we can give it while they are admitted, but as soon as they are discharged, they cannot get their methadone in the hospital anymore, unless that hospital is set up as a special clinic, and most of them are not. So, food for thought to please keep in mind as you are talking with people and making plans and giving them that education, to make sure that they have a plan for when they are discharged. If their baby's staying for 5 days for monitoring, how are they going to get their medications in that discharge period? And great, if they have a 24-hour postpartum course, very smooth vaginal delivery, and someone comes in the next morning and they're like, hey, you're 24 hours, you're hitting all your milestones, we're going to discharge you today. Like, making sure that patient knows, like, my insurance will cover 2 days and I can ask for 2 days. Because if I stay for that 2 days, like, I can safely get my medicine here and I don't have to figure out travel and driving 40 minutes to my treatment provider. So just something to think about. Your buprenorphine products, you're either going to come across the monotherapy or the combination product. Monotherapy does not have naloxone in it. Combination therapy has the naloxone component in it. Please keep in mind that naloxone component is in there as a safety mechanism for if the medication is not used correctly. So if it is smoked, if it is IV injected, if it is used in a way that is not sublingual, that naloxone will go to work. If it's used sublingually, it is not doing anything in the body. And this trips people up all the time. We'll talk about that. So just to open it up to people, do we need to take people off of Suboxone and put them on Subutex to give them pain medicine? I see an awkward head shake. No. You do not need to switch them to monotherapy to be able to give pain meds, but that's something that I just got a phone call about last weekend asking me if we needed to do that. So it comes up a lot. So I think that this mystifies people a lot. So I did want to take just a couple minutes to break down. I've realized in working with my residents that a lot of people don't really understand what the actual Suboxone prescription that you might see is. Because since it does have the naloxone component, there is a second little, when you see the little medication written out, it'll say 8/2 or 12/3. And sometimes people are like, I can't make heads or tails of what this actual medication is. So that first number, so I'll draw your attention to this one right here where it says 8 milligrams. This would be a Suboxone 8 milligram film. The second little number, the slash on that, is referring to that naloxone component. So I always tell my residents, I need you to just cover that part mentally. To not pay attention to that one as much so you don't get lost. So whenever we have people that come in and they're like, I do 8 milligram films, I do 2 films, that means they do 16 milligrams daily. And so that's important to be able to wrap our brains around, and how much are they taking daily, so that when they come in and they're having acute pain management issues and we start trying to think about getting around having withdrawal symptoms in the third trimester, and how do we go about like trying to optimize our dose postpartum, that you can do divided doses to try to help utilize the very slight amount of analgesic effect that you can get. So let's say somebody is on the 8 milligram films and they do 2 films daily. So they take 16 milligrams daily. If they were like, I'm feeling gross, I want to try to split this in like to twice a day, they're going to do 1 film in the morning and they're going to do 1 film in the evening. Easy, nice and clean, right? We like when it's just 1 full film and 1 full film. Let's say that they come into the hospital and we're wanting to try to take advantage of that little, very slight analgesic effect that happens. And we're wanting to like really try to keep them nice and steady. If you were going to split that into 4 doses, you would cut it into half films. So 4 milligrams, 4 times a day. And I'm very visual, so I have the math written out there for you guys. So looking at how we can take that dose and divide it up if needed for people can be helpful. If your institution, and that's something that I always like tell my patients to ask about if they're not delivering at at the hospital I work at and they're going somewhere else. Let's say that they don't have Suboxone on formulary for them. What do I do? Inpatient, they can do Subutex while they're there. It is going to be the exact same dose. We don't got to do fancy math. If they're on 8 milligrams of Suboxone and they go into a hospital that only has Subutex on like their formulary, great. They can do 8 milligrams of Subutex. But that always trips people up as well. It is the exact same dose back and forth. You don't have to do any crazy calculations on that. Naltrexone is not currently approved in pregnancy just because there's a lack of data. Now, there are some studies that are coming out. Again, I said I'm not going to spend a ton of time on this, but there is a manner in which you can switch people if they're on the injectable form over. There's protocols to switching to oral dosing. I wouldn't expect like anybody really that's in this group to be going through and actually doing the change for that, but mainly just for you to tuck away that if someone is on naltrexone, that they really should be working with their prescriber to come up with how they're going to go about like planning on making changes for their delivery. And there's a really beautiful flow sheet that's available online. It just wouldn't like copy into my slides well, so I made you guys a very generic one, but the link is in the reference list if you ever were curious and wanted to go through what the process for that would be. Several myths that come up because, you know, labor and birth, that's what everyone, and postpartum, that's what everyone's always interested in, right? I get people in new OBs all the time that like as soon as they come in for their new OB visit, they're like, I want to talk about all of my birth plans. So the labor part is actually pretty streamlined and easy for people, I think, with medications for opioid use disorder on board. It's the postpartum part that's mystifying. But there are still a lot of myths that come in with the labor and birth phase. So if you're on medications for opioid use disorder, you are not just stuck with an epidural. It'll work great, but that's not your only option. It again will work. So I've had people who have been told that they can't have one because they're on Suboxone, and that is incorrect. And then also there's just an entire plethora of stigma and bias that comes into if you're going to have a medicated birth or an unmedicated birth and what that means. And if you're seeing a midwife, are we a bunch of crunchies that aren't going to let you have any relief and, you know, all of those interesting things. So when we're doing any kind of pre-labor planning, very crucial to make sure that you're building in that trust and you're documenting that really clearly. And so the biggest thing that I see that happens when people come in labor is that I'll hear horror stories all the time that people came in and they stopped giving them their Suboxone because they were like, we need you to quit so that we can control your pain. Frequently, I will get told stories or I'll get a frantic message from somebody that's like, hey, they called me for my pre-op consultation. I'm having a scheduled C-section. The pre-op nurse called me and told me that I should quit my Suboxone 48 hours before my C-section. And they know that it's wrong in their brain, but they're panicking. because they're like, but if I do it wrong, how am I going to have my pain controlled? And so when we think about why we put people on a medication for opioid use disorder, when we look at it through like the lens of like, why do we do this? I think it helps to like understand like why you maintain them on their meds. So we put people on these medications so that they reach a steady state, so that we don't have harmful cycles of use and withdrawal and inconsistency and bouncing all over the place. So we recommend initiating therapy and maintaining therapy so that we're nice and steady. So it's always perplexing to me why, like, if this is the mentality that we have, and we know a lot of providers have that in their brain. We'll think about our case study, right? That provider was like, I know withdrawal's bad, so I'm going to give you the most meds so you don't withdraw, right? So we have this buried in our brain. We've been taught that. But then we just flip it when they come into labor. Whereas that's really when we need to keep the steady state going. So our first, number one, most important thing is, regardless of what kind of birth they're having, it's a vaginal birth, it's a C-section, we are going to maintain their dose. We are not going to make the people sick in the middle of labor. So we maintain the dose. If it's an outside provider, you can confirm that dose. Now with the legislative changes that we've had, confirming the dose should absolutely not be the barrier to the person getting the dose. So you do want to make sure that you are maintaining what they're doing. The other thing that I would caution, and that's the thing that I think gets a little bit sticky, is, so take, for example, our lady who was getting prescribed 16 milligrams and is very transparently telling you, I'm only taking 8. We do not need to force her to take 16 milligrams in the hospital because that's what she was being prescribed. So just making sure you're clearly documenting that you talked with her and she's like, look, I've only been taking 8, and making sure that she's maintaining her dose. Please, please, please believe that they are in pain and treat their pain if they need it. I teach undergraduate nursing students, and I love my lecture on labor because I'm like, all right, guys, tell me what you know about labor and birth. And literally the first thing that they say every time is, it hurts. Like, never fails. They're never like, oh, it's beautiful, it's magical. Like, and just, it hurts. That's what they know to be true. And so if we know this to be true, my little nursing students that haven't seen a birth yet, general rest of the population probably knows. You bet our patients coming in are going to know that labor and birth can hurt. And so we need to, as the team taking care of them, remember that it hurts and make sure that we're believing them and treating that pain. There are only really 2 big no-nos to file away. Like, we absolutely do not give them nalbuphine or Nubane. We absolutely do not give them butorphanol or Stadol. So those are your 2 biggest no-nos walking away. And I always tell my patients that. Sometimes, like, things get scrambled, things get busy, things get put in on the wrong people. So I always like to make sure that my patients know, like, you should, if anyone comes in and is like, oh, we're just going to give you some Nubane for pain, they should absolutely say no to that. So that they then get that autonomy and that power to know, like, that one's going to make me get precipitated withdrawal. I'm going to get real sick. So something to keep in mind. ACOG, so that's like our main group over obstetricians and gynecologists, has some, like, honestly really pretty straightforward new recommendations in their entire, like, bulletin on opioid use disorder. So very clearly says that they should maintain their dose, and then they should receive additional pain relief if they need it, and that you could consider dividing their doses into every 6 to 8 hours in that acute pain phase. So very straightforward. Quick word on, again, I'm all about the non-pharmacologic relief. Continuous labor support, especially for individuals with substance use disorder, is crucial and huge. This is an area that hasn't been nearly as well studied with this population as should be explored. We have good evidence for peer support with substance use disorder. We have good evidence for doula support in labor. Side plug, we don't have a lot of evidence for peers getting doula training to provide that beautiful crossover. But we do know that if you have someone there just supporting you, educated on labor and birth, that it will lead to lower interventions, decreased need for pain medication, less birth trauma, and a decreased risk for C-section. And so doulas are going to be able to help guide that person through and give them some of those non-pharmacologic pain relief options to help with managing pain. That can be really useful for people that do not want pain meds in labor. As a midwife, I see a lot of people that do not want pain meds in labor, and that is okay. So non-pharmacologic pain relief, position changes, calm environment, hydrotherapy is great, hot and cold therapy, massage therapy, or manual touch, depending on the level of comfort with touch. Consent and trauma-informed care can go an exceptionally long way for helping people to manage pain. And also just controlling the room and making sure that it's not absolute chaos in the room. My pain's going to be a lot higher and my stress level is going to be higher if I'm living in this setting versus this setting with my experience. So something that your patients can know, like, it is your space and you can absolutely turn the lights off and bring things for comfort for you and make whatever you need to for that. A lot of times whenever we look at under treating acute pain, so we've done all the juju, we did the good vibes, we've done the massage therapy, we've got just like a lovely doula in there working their magic, and we're still having significant pain and need that managed. That's when we're going to start looking at other types of interventions. And so your epidural is going to honestly give you the most complete pain relief. So my people that are very afraid of pain and they do not want to feel anything, I usually recommend an epidural. That's really scary for people because it's a needle. So really making sure you're like on the labor and delivery side or in the office, that someone's like walking them through like what the process is for an epidural and reassuring them that that needle is not staying in their back, because I've found that that's where most people's fear comes from, is the fear that the needle's hanging out in there forever. But epidural is going to work just as well for someone that's on a medication for opioid use disorder. That epidural space is completely different. It does not matter if they've got Suboxone on board. They're still going to get relief with that epidural just as much as somebody else would. And so giving them that reassurance. I've had anesthesia not give people Duramorph into their spinal during a C-section before because they saw naloxone and thought, oh, it's not going to work. Long-acting injectable opioids into the epidural space, especially like with a spinal, will still work and will still give good relief. And that's something that they should still do. Making sure that if you are giving any kind of opiate in labor, if you're giving fentanyl, if you're giving morphine, that those are safe and you can do those, especially if someone really wanted an epidural and maybe their water broke while they were waiting and now they're in a lot of pain, or they're having a hard time sitting still for their epidural and they need something for IV breakthrough pain while they're getting that set up. You can absolutely do fentanyl and morphine. I would always like talk to them and make sure that that's something they're okay with. Again, that's something that's really great to talk about before they're in pain. So you get good like passage of information. My one plug is to really make sure that that's documented thoroughly with times as medications that are given in labor. So if someone got fentanyl in labor, they could have that show up on a cord segment, especially depending on how long their labor lasted. And I've had 2 people that have come through my care before that me having very careful documentation of when they got fentanyl has made the difference in CPS, like really stepping in and trying to make some changes. So important to keep an eye on. I'll usually try to, when I come across people in the hospital, go back, look at the times and like print and write them out so I can hand them a paper to have of like what times they got medications, just so that they have that. So making sure that that they know to ensure that that's documented appropriately too. When you look at those medication specifics, you can, like we mentioned, like you could consider doing split dosing for any of your opiates while they're there. You do not want to replace someone's methadone with buprenorphine, but I've also been asked that while they're in the hospital before. So that would not be the optimal time to go changing someone's medication for opioid use disorder. if someone's on methadone and you're wanting to use buprenorphine for breakthrough pain, not recommended. We are not crossing those two together. Those are very separate. So just something to remember. Specifically for buprenorphine, we already mentioned that you could split the dose into 3 or 4 times a day. You could consider, if you didn't have Suboxone in your facility, doing Subutex, but you do not have to make that switch. An epidural and a spinal will work just fine. You can do the same IV meds we already talked about. There is some like increase in interest in using PRN buprenorphine for pain control. So trying to like on top of the maintenance dose, do 2 milligrams every 2 hours. We don't have as much data on that, especially in the pregnant population. We don't really have any data on that at all. It's something that you could explore if you had someone that really aggressively did not want opiates and was only comfortable taking buprenorphine. But I do just want to make sure that it's very clear that only substituting and only giving people buprenorphine just because of the provider's like fear and discomfort with opiates is not appropriate, and that's not a good use of that regimen. And again, just to drive it home, if you give any medications that would show positive on a drug screen, really important to document that with appropriate times. So postpartum, just to like kind of close things in, most people with a vaginal delivery do pretty well with postpartum pain management. I honestly don't have a lot of people that usually need any kind of additional opiates, even if they're on a medication for opioid use disorder. This one's usually pretty easy to bounce back from. Now, if they had a really bad laceration, like 3rd or 4th degree, if your patient's like, I'm just really hurt and I tore all the way to my butthole, valid. You might need something more for that. So if that's the situation, opiates would be appropriate for that. And we'll talk about how like prescribe, like how that would work and what you would do. Really for most vaginal births, like your non-pharmacologic interventions are going to be huge for these people. So ice packs, witch hazel. I've usually got ice on the vagina and like heat on the uterus to help with the cramps and to help with the soreness down below. Anyone that's had more than 3 babies or they had twins and has a big stretch on the belly, abdominal support binders still really helpful after a vaginal birth to help to like pull all the structures in and make them feel less like everything's just kind of like swooshing around in there. Your postpartum healing sprays, so like Dermaplast, Freedom Mom, Lancino, there's a ton of them. All of those can work really great for people. And so I'll usually try to encourage if people can get their hands on it, if they've got like friends that are like, what can I bring you? You can bring me a can of Dermaplast spray. Thank you. Some hospitals have it on formulary that you can order, which is nice if you have them ask for it. C-section pain management is the one that I think always mystifies people and where we struggle at the most. So at my facility, and the tough thing is that other hospitals are not very transparent in what they do, like with their protocols. So if you actually try to like go through and look up, like, what are your pain management protocols? Johns Hopkins and Cincinnati and all of them, like people do not like freely put those out there to see what other people are doing. So at my facility, usually people will intra-op in the spinal space with their like anesthesia. They'll get Duramorph, which is a long-acting opiate that works for 24 hours. For the first 24 to 48 hours, they get scheduled Toradol, which is like, I always break it down for people like a really good Motrin through the IV every 6 hours. And then after they get through that first like 24-hour window, that's typically when they start switching the general population over to oral medications. And so your standard things that end up getting ordered are ibuprofen, 600 milligrams every 6 hours or like 4 times a day. Tylenol every like 6 hours or so, 4 times a day, and then an opiate as needed. There are also like enhanced recovery after surgery protocols where you can consider doing gabapentin for pain control, either like right before the surgery or after. Lidocaine patches can do a lot of good as well. Those actually work a little bit better if you cut it in half and run it all the way right up above the incision versus the big awkward square just slapped on their belly. So good placement on that. But when we look at opiate use, we don't bat an eyelash with people that don't have medications for opioid use disorder on board. So like my residents are very used to like, all right, post-op C-section, I'm going to put your Tylenol in, I'm going to put your Motrin in, and then I'm going to order Norcos for you or Percocet. We're going to give you 5 milligrams every 4 to 6 hours, like every 4 hours as needed. Great. And they move on with their day and they don't think a thing of it. In the general population at discharge, our policy is we go back, look at the last 24 hours and say, all right, over the last 24 hours, you used this many pills. We're going to multiply it by whatever the common denominator is that just left my brain. And they estimate how many you're going to need for the next like 3 days. And we send them out the door and nobody thinks anything of it. As soon as you sprinkle in that somebody is on Suboxone or methadone or Subutex, everyone gets in a tizzy and then they're like, well, we got to give them opiates now. And the answer is that if they still needed it for pain, they can, if the patient's comfortable with getting it. The thing is that to get a kind of stimulation on the receptor, to get anything there to go to work, you're going to have to give them more than you would give the average population. The exact numbers, I'm pretty sure, is that in one study, people on methadone needed 77% more medication, and people on buprenorphine needed 43 or 47% more medication. And so what that usually looks like is if we're giving people an average of like 5 milligrams of oxycodone, then maybe they needed 10 milligrams of oxycodone, or maybe they needed 15 milligrams of oxycodone. Obviously, you would start low and then start titrating up to see what they needed. Obviously, you're going to go through and you're going to make sure that you're giving an appropriate prescription on discharge if they needed it. That's the thing that makes people very fearful and nervous too, is sending like people home on meds. But if you think about it, if you just used pain meds and you got good control from the beginning and you were like, I'm thriving, I'm doing great, I only need to take pain meds like 2 times a day, yay me. And then we just kick you out to go home and move around more and climb your stairs and walk further than 5 feet to your bathroom, your pain's going to get a lot higher and we're going to put you in a situation. So making sure that we're remembering what they needed before they left when we're discharging them. I think it might be on my next one. Yeah, we're going to skip very quickly ahead just to discharge planning. Is when we are considering, especially when people get nervous about like sending them out the door with meds. If your patient was on medications for opioid use disorder, their baby's going to stay for 5 days for monitoring. And I know in my hospital, usually people get discharged on day 2 to 3 and they room in with their baby. And so that means that while that patient is discharged, they're still there and you still have a level of contact with them and they still have that access. And there's no rule that you're not allowed to like check in on how they're doing. That doesn't mean like, I'm going to go in and like, I need to do this like full assessment, but you can do like a quick check-in to be like, hey, I just wanted to see how you're doing. How's your pain? If it's not managed, if they're not okay, if they're not stable, you readmit them and you reassess things. If I had someone not on those medications that called me 3 to 4 days post-op and said, I'm in a lot of pain, I don't know what to do, I would bring them into the office and evaluate them and see what they needed. So really easy check-in that we have an option for that we kind of forget about. Because, you know, we discharge them and then they're off our list and we don't think about them anymore in the OB land. But they're still there. And so it's something that you can think about and keep an eye on things. My other side note, for all of you working with people on treatment, like from the community side, making sure that they know what to do with their maintenance meds, making sure that they bring it to the hospital. Because if you got discharged on day 2 or day 3 and you're staying there with your baby for 5 days and you're on Suboxone, if you didn't bring it with you, that means you're going to be without your Suboxone in your room for a couple days. So making sure people know it's okay to bring your medicine to the hospital. If your hospital has a policy that that's really not allowed, making sure they have a plan for someone to get their medicine for them. That's something that we forget about a lot of times. Is I can tell you that my team gets clicking through the things, and it's really easy to just like click continue your maintenance medicine, continue that Suboxone, but we didn't figure out if you actually had it with you and if you could continue it. Because the thing that's gonna not go well is if they didn't have their maintenance medicine while they were in the hospital. So thinking through those little tidbits as well. Now, when people do get pain meds in labor, no contraindications for continuing breastfeeding. So spinal and epidural, absolutely no contraindications with lactation. They are good and fine to breastfeed. People who are on methadone, Suboxone, or Subutex, very safe to breastfeed with. And of course, we're going to recommend that if they're a safe and stable person in treatment. If they got fentanyl or morphine in labor or they needed pain meds, we are not usually telling them to pump and dump afterwards, but that's sometimes a fear that people will have. And so just reassuring them too that if they got pain medicine or if they're needing it, that it is okay for them to breastfeed. One of the biggest impedances on your milk coming in and you being able to successfully like feed your baby if you really wanted to breastfeed is if you're in such bad pain that your cortisol is so high that it interrupts that. So that's an important thing just to think of. When we discharge people, especially if we're sending them outside with medication, to close the loop on that fear that we have of pushing people to returning to use, we just need to do really good postpartum follow-up. So these are not the people that we like discharge out into the world and we're like, see in 6 weeks. Like these are the people we see back in a couple days to check on them. One, they had a surgery. You should absolutely check on them. If they had a vaginal delivery and some complication, you should absolutely check on them. If you're working with them in the community, they might need debriefed with some of the things that happen in the hospital. Absolutely check on them. Making sure people have a Narcan prescription on discharge if they didn't already have that in their possession is huge. Just keeping in mind that your unresolved pain and stress from all of that is going to probably be one of your biggest triggers to have a relapse or to use. And so making sure that we're appropriately treating people's pain, but also like coming in and giving them that support and making sure that we're following up really well. And that's everything. I'm sorry I was long-winded and I did not leave 10 minutes for questions like I wanted to. I'm very sorry.
That's good job, Kelly. It was a lot of information, great information. I did see one question in the chat about insurance paying for pain meds in Butte. Is that possible? Do we know?
I have not had a problem with that personally, with people covering it. Now, what I have had a problem with is when people use buprenorphine PRN for pain control. Insurance will not cover that, and usually people have to pay cash for that. Sometimes they'll like flag it and be like, yoo-hoo, just as a notification to be like, did you know this person was on it? But usually once you're like, oh yes, they had a major abdominal surgery, then they're like, oh, okay. I'm curious if other people have ran into that though.
Any funding for doulas?
Yeah, so we are not in a state yet where Medicaid is paying for doulas, but we are moving in that direction and working on that. So the West Virginia Perinatal Partnership has a doula working group where they've been able to help support people getting doula training, such as like shout out to Candy Cooley who did her doula training, so that we can then collect all of those outcomes from people and be able to have a big juicy body of evidence. And I see Shauna on here, so Shauna is actually like leading that. Sorry, Shauna, I'm over here running my yapper when you're the expert and the queen on that.
Hey there. Yes, we have Unicare to thank for that, and Carrie Harper is on there too. So we have hired Annie and Barb White, and she will be leading the doula charge now. And so we're really pleased with that and all of our activities. We have probably over 60 doulas now trained, so we have to get them in the work sites. So if you are responsible for being a fearless leader in the labor and delivery suites, please, please, please befriend a doula, and shoot me an email, and we'll hook you up with a doula in your area.
Great. Thank you. We are a minute over, so just want to be mindful of everybody's time. Thank you for everybody for joining. Our next session is going to be on November 13th, looking at the treatment of NAS. So be on the lookout for more information on that. And thanks again, Kelly, for the presentation. Everybody will be getting the slides and the recording here later this afternoon. We'll see you next time.
Thanks, everyone.